This session is going to be, the second group is post laser vision correction. What are we going to do? And we have dealing this controversial issue, Dr. Vardhaman Kankariya, who is a young, dynamic, smart cataract refractive surgeon from Asian High Hospital, Pune, and is also the chairman scientific committee of MOSCON. And we are all going to be experience the fantastic way he's going to go about it. And all the best to you, Vardhaman. We really look forward to a great meeting there. And he is going to be talking on monofocal would work best. Countering him is going to be Dr. Vijay Kumar, who's our senior consultant cataract, medical retina and glaucoma services at the Eye Foundation E Road. Vijay, your face is not being seen. Somehow it's a blank there. Adjust your lighting. And he's again another very versatile surgeon. And he's going to be talking on why not trifocals. And we have Samaresh Srivastava, who's again another very prolific surgeon, who's a consultant ophthalmologist at Raghudeep Eye Hospital based at Jaipur, and is doing a wonderful job there. And he is going to tell us why not EDOF. So we are going to fight with monofocal, and we are going to fight with trifocal and with EDOF. And we have Dr. Ramurthy to give his expert view for 5 minutes. So everybody stick to your 6 minutes, and Vel Murugan will give you a warning at 1 minute. So on to you, Dr. Vardhaman. Let's hear from you.
So first of all, thank you, ma'am, for the kind invite. And I'm going to talk to you about why I believe that the monofocal lenses work the best post laser vision correction. We all know that when the baby boomer generation came and who have actually experienced the first wave of LASIK with the older generation LASIK procedures, which had broad beam lasers, probably not appropriate pupillary tracking systems. But of course, these are the first people who were exposed to the magic of LASIK. These people have relatively like intolerance for diminished vision, and they are the ones which are coming in for cataract surgery now. They demand as good as outcome as refractive procedure from their cataract surgery as well. So what the patients desire today, the patients who are undergoing cataracts desire an accurate refractive result. They desire, of course, a great quality of vision, and they desire a stable and non-fluctuating vision. The issue with the laser vision correction is that it is, especially if you're going for higher optic lenses, such as multifocal lenses or EDOFs, is the unpredictability of refractive results, the added higher order aberrations of both LASIK and this higher optic lenses, and the pre-existing dry eye, which also is going to become worse with age. These three things, they confound and give rise to unhappy patients in majority of these patients, not in all of them. Therefore, I'm going to stick to monofocal lenses for vast majority of these patients. So basically, we all know that in patients who desire this most accurate postoperative refractive errors, these IL calculations are unfortunately less predictable. And there are three errors that we look at. I'm not going into the details of them. First of them is called as an instrument error, in which you know that the keratometers of today are actually looking at the paracentral points and not actually and missing the central location. The second one is called as a refractive index error, because the ratio of your anterior curvature and the posterior curvature is considered to be fixed, and post laser vision correction that is going to change. So if we don't consider the posterior surface of the cornea, we are going to land up in hyperopic shift or hyperopic surprises post laser vision correction IL formula errors as well. And the third one is called as a formula error, because we all know that the current formulas that we are using, which depend on the prediction of the effective lens position, they become erroneous because of the change of the corneal shape. And these errors altogether give rise to a final hyperopic surprise post-refractive errors. We all know that whether it is EDOF or multifocals, they all perform the best in an immetropic optical situations. All these modifications that we have come to, there are a lot of newer advancements which have come with the IL formula, especially with the help of double K, Aramberi's method, Shama's method, Heges-L, and Barrett's true K formula. Now, many of them are clubbed together, and that is seen in the ASCRS formula on the ASCRS website. But in spite of all these things, a lot of studies have actually shown that your ability to come to emmetropia is seen to only, let's say, between plus 0.5 diopters is only 67% of the eyes where you are actually using a Barrett-Ruque method. Heges has also demonstrated that it is seen in only 61% of eyes. There has been a very elaborate study which was done, which have compared Heges-L, Barrett's true K and also the Alcon's ORA systems for the intraoperative aberrometry nomograms as well, along with the ASCRS calculator, and their mean achieved immetropic values were seen only in 74 to 76% cases. I was a part of a study at Bascom Palmer Institute, which looked at the unhappy multifocal lens outcomes. And one of the most important reason for unhappy outcomes for multifocal lenses is residual refractive error. So this residual refractive error, because of the unpredictability of the formula, is a recipe of unhappiness for patients who are post laser vision correction, especially if they have been done by the first generation of lasers. The second reason for unhappiness post multifocal and EDOF lenses is, of course, dry eye. We all know that LASIK is going to induce dryness because of the first creation of flap and also ablation on the subepithelial nerve plexus. Of course, this have got reduced with advent of SMILE, but majority of the current generation cataract patients that we are seeing today are all post LASIK patients. It has also been seen that LASIK is known to also have a slow recovery of dry eye. And in the older age, this dry eye is going to get compounded by the age-associated dryness that we see today, and especially in the avenue of patients who use a lot of computer work. This has also been seen that if you have a patient with dry eye, there is always a challenge also with the unreliable keratometry because of the unreasonable Myers. And this also plays a part to have actually unhappy patients. The third reason for unhappy patients post LVC is, of course, the older generation lasers, which have already induced higher order aberrations. And on the top of that, it is also seen by a variety of studies that this both spherical and the coma aberrations can actually get induced a lot, and that can give rise to a lot of, let's say, aberrative corneal issues and the optical phenomenons for our patients. This study has actually looked at the diffractive multifocal IOL implantation in myopic post-LASIK patients, and they have actually compared these aberrations in virgin eyes versus the post-LASIK patients, and they have seen that both third and fourth order aberrations were much higher in this multifocal lenses post-myopic LVC patients as compared to the virgin eyes. This is a very nice analysis which had looked at the contrast sensitivity of this multifocal lenses post laser vision correction. And they have seen that the best contrast sensitivity is retained in patients who have virgin eyes, and the worst contrast sensitivity is actually seen post LASIK patients who have already done with the multifocal lenses. So this is the analysis of the point spread function, which has also shown clearly that compared to the current generation of multifocal lenses or EDOFs, the monofocal lenses will always have much better quality of vision in these patients. So for me, for majority of the patients who now revert back to us, now we have been in refractive surgery for last almost 38 years. And we have been doing LASIK ourselves in our centers since 1994. So whenever we look at our own patients who have come back, who are coming back to us for cataract surgery, my primary basically aim is to offer them monofocal or a monofocal toric IOL. We also do a bit of monovision for these patients. Because monofocal lenses do not induce much higher order aberrations, the maintenance of quality of vision is much better. The patients are already known that they will need some form of small spectacle numbers, which they are already happy about. The way we go on about choosing the lenses is that for patients who have already undergone a myopic LASIK, because there is already an increase in positive spherical aberrations, we select a negative aspheric IOLs such as Technis. And for patients who have undergone a hyperopic LASIK, who have an increase in negative spherical aberrations, we go on to choose A0 aspherical lenses as such. For very small subset of our current patients, we still choose the trifocal or the EDOF lenses, where we see that the laser ablation has been done by more recent generations of corneal lasers. And the zone of ablation is very wide. It is a very well-centered optical zone. And we look at the EKR graph. If the EKR graph depicts that it is a very well-centered ablated cornea, then only we think about the multifocal or the EDOF lenses. But the patients are always told about possibility of requirement of laser enhancement if we don't actually reach the end point of immetropia because of the unpredictability of the errors as well. Thank you very much to Dr. Chitra ma'am, and over to the next speaker, please. Thank you.
Very valid points, Vardhaman. We look forward to the discussion. And I would largely request Dr. Prema Padmanabhan and Dr. Namrata, and if time allows, a little bit from Dr. Gaurav on this in this session. So be prepared for questions. And we go on to Dr. Vijay Kumar now, who's going to tell us why not trifocals post laser vision connection.
Thank you so much, madam. Thank you for the opportunity. Good evening, everyone. I'm going to talk about why not trifocals post laser vision correction. So since the 90s, the laser vision correction is the most performed procedure all over the world for spectacle independence. Since the 90s, there are over 40 million procedures done all over the world, and it's still now, so far, it's still counting. And the early beneficiaries are now aging. They've either reached presbyopia or either they developed visually significant cataract. So these are the two subsets of patients who are the early beneficiaries of laser vision correction in the 90s who come to our clinic. The first subset who have not developed cataract, who come to us with presbyopia, will come to us saying, I don't want to wear reading glasses at all. For such patients, we have options like monovision correction by lifting the LASIK flap and doing an examination laser. The second subset who have developed visually significant cataract, they come to us again saying that they don't want to wear glasses post-operatively. So first, for such subset of patients, we would like to do a multifocal IOL implantation. Currently, we have this trifocal IOL design with toric. So the advantage of placing in trifocal IOL is it provides intermediate visual acuity without sacrificing distance and near vision. And the contrast sensitivity is also shown to be good if the cases are selected properly. So this is a major study done in 2021, which was published in JCRS by Rosario et al., which has shown that the current diffractive trifocal IOLs are compatible with the photoablated cornea with adequate predictability, efficacy, and safety outcomes. So the biggest conundrum in doing a trifocal IOL in a post-LASIK eye is to identify the exact power to implant in the eye to achieve emmetropia. So we would generally take up a aspheric IOL design so that spherical aberration is negated. The traditional IOL power calculation formulas no longer apply in a post-LVC eye. In myopic correction, the anterior corneal surface gets flatter, resulting in lower K readings, and the ratio between the anterior and posterior corneal curvature also gets altered. The asphericity becomes oblate from prolate. So the IOL power generally gets underestimated if we use SRKT or Hofer Q formula, because the effective lens position, as Dr. Vardhaman has already pointed out, is getting underestimated because of the flattened cornea. But still we can achieve emmetropia with careful case selection and assessment. So what are the important things to assess preoperatively is the most important being ocular surface. As Dr. Vardhaman has already mentioned, LASIK causes some element of dryness, and with aging, it gets accentuated. So it's important to assess the tear film stability using a LipiView, a TBET, or a Schirmer's. And in case if it's unstable, we have to treat it first and make it stable, and then proceed with corneal topography. And once the corneal topography, we get to know the steep axis where to place the incision, and also it will help us to estimate the central corneal power. Newer generation formulas need central corneal power to exactly identify the intraocular lens power. And also with the topography, we can identify whether it's the post-LASIK topography shows regular cornea, especially in the central 4 mm zone, and the topographic results are reproducible and repeatable. And also the centration of flap along with higher order aberrations, especially coma and spherical aberration. And also we will also get to know the angle kappa. Using ray tracing with eye trace, the corneal aberrations can be distinguished between which the aberrations are from the corneal surface or by the cataract. Wavefront aberrometry is also important before surgery to assess the severity of corneal aberrations. The ratio is kept between 0.3 to 0.5 to give accurate measurements. And this is one of the post-LASIK eyes with good centration and with minimal induced higher order aberrations like trefoil and coma. Accurate axial length measurement is very, very important in assessing the IOL power. So the optical biometry using the IOL master 700 lens star would help, and it should be rechecked using an immersion A scan. A proper dilated fundus examination is essential to rule out any myopic macular and peripheral degenerations before proceeding for the surgery. And an anti-segment OCT to assess the exact corneal thickness, LASIK flap thickness, and stromal bed. In case if we end up in a surprise post-op, we might need to do a bioptics. This would help us for post-operative adjustment. So this is the most important step, IOL power calculation, because the main error is using a normal usual formula can underestimate the IOL power because it assumes that the anterior and posterior corneal curvature is the same. But in a myopic LASIK, the anterior corneal surface is flatter, resulting in a lower dioptric power IOL implantation, which would cause hyperopic shift in such patients who already had a good near vision. The visual acuity worsens for all distances. So these are the important formulas which will help us to assess the intraocular lens power. Haig is L, which will be useful in myopic and hyperopic patients. The Barrett true K, which is equal to or better than the online calculator in myopic LASIK and post PRK. The ASCRS online calculator using Potvin-Hill formula and Barrett true K, which gets the input from Scheimpflug as well as OCT. And the method to assess the corneal power is Wong-Koch-Maloney method. Angle kappa is again an important thing before proceeding for a trifocal IOL. It's the axis between
1 minute left.
Yes. Shall I proceed?
Yes, yes.
Yes. So angle kappa is the angle between the visual axis and the pupillary axis, between the white and the blue dot. So this is very important because especially in a post-hyperopic LASIK patient, they tend to have a larger angle kappa. When we place a trifocal or a multifocal IOL, there is a chance of post-operative lens decentration, which would increase patient dissatisfaction. So for such patients with slightly larger angle kappa, it would be better if you use larger central optic zone IOL. So these are my evidences where in a post-LASIK eye, a trifocal IOL implantation has been done, especially in this study by Rosario et al., which was published in JCRS in 2021. 868 eyes have been assessed, wherein 319 were myopic and 549 for hyperopic. The conclusion shows that there is good visual outcomes in high myopia and good precision in hyperopia. The next supportive study is Brenner et al. In breast-perfect lens exchange with the trifocal IOL post-corneal LVC. There is utilization of optimized IOL constants. Nomogram can improve refractive precisions, which will give a good refractive outcome. So the most important step again is counseling. We have to tell the patient that patient has to be patient for at least 6 to 8 weeks post-op, because the initial 4 to 8 weeks, there is a chance of corneal edema or flap edema, which can cause glares and halos. So we have to wait for 6 to 8 weeks to reduce the inflammation completely, reassess the eye at 6 to 8 weeks, which will give excellent visual acuity if the preoperative assessment is done properly. And there should be the patient should be given extra chair time to focus by lowering their expectations. And this should always tell that there might be a need for secondary procedure in case we end up with a refractive surprise like an IOL exchange or a TCAT. And there are important steps during surgery.
You have to conclude, Vijay.
Yes. Yes, the 3 important steps in intraoperative precautions is to placement of incision. It should avoid a LASIK flap, and it should be outside the flap to minimize damage by the phacotic cannulas or accidental instillation. And in case of post-operative fine-tuning, there shouldn't be no problem in lifting the flap. Thank you so much.
Yes, valid thoughts, Vijay. So let's hear from Samaresh before we take on and of course, our expert panel's view.
Yeah, I hope I'm audible, madam.
Yes.
Thanks a lot for inviting me for this talk. And I'm going to be discussing why not the newer generation of enhancing the depth of focus for post laser vision correction patients. And I just wanted to break the ice by saying that there are many types of lenses. We are not discussing diffractive lenses for my talk, which are also claimed to be EDOF lenses. We're discussing purely lenses which increase the depth of focus. And how they do it is by actually distributing the light intensity, as you can see over here. If I get move the cursor, a monofocal lens also has certain intermediate profile, but a lens that has an enhanced depth of vision will increase your length of focus just like a shallow depth of focus lens, and give you a larger, more continuous zone of vision, which mimics natural vision. So it stretches and shifts your focus rather than splitting, as would a trifocal lens do, or any diffractive lens do. To address the elephant in the house, we've been using the Barrett-Truquet formula, and I think with that formula, we did do a study which we published, which was to compare the IOL prediction in both the prediction error and the refractive prediction error of 4 commonly used formulas: the Wangcock, Maloney, Sharma's, and the Barrett-Truquet, which is available for free on the ACRS and APS-CRS as well. We found out that the prediction error was least with the Barrett-Truquet and also with the Sharma's formula, and this was statistically significant compared to the other formulas. And we talk of refractive error prediction error also, it was the least with Barrett-Truquet formula, so we were well within 0.5 diopters for most of our patients. So I think at this point in time, with the kind of formulas that we have available, the ever prominent issue of whether we hit target emmetropia or not is less important in today's generation with the better formulas in it. And this is what we concluded, that all formulas performed well, and the highest number of eyes within 0.5 diopters was with the Barrett-Truquet, which fortunately for us is available for free. So with this, I will show you some real life examples rather than some theory, because this is what actually happens in the field. So this is this patient who's about 40 years old, and he's had Contura with me, femto LASIK, Contura vision about 5 years back. He landed up having a COVID infection and developed steroid cataracts in both the eyes, early PSCs, but being a patient with active lifestyle, he had to undergo surgery. Now, this is typically how a LASIK would look if it's done well-centered. This is particularly because it's a topography-guided LASIK. You can make out, if you look at it on the right side, that it's a fairly well-centered ablation zone and really well within the pupillary area. And this is the patient's not photopic, not mesopic, but an ambient light pupil, which is where he would be most of the time. And it's a very well-centered ablation profile. And so happened with the left eye. Now, when we plan a cataract surgery, particularly for patients who've undergone any sort of corneal procedure, one needs to keep in mind that what we need to see is the pupillary area or the pupillary axis and the zone of the cornea within the pupil. And the rest of it does not matter as much. But in this case, since it was a wide zone ablation, we safely went ahead and did a surgery and bang on target. This is just a screenshot from my EMR showing literally nothing came out in terms of subjective refraction. Obviously, the AR did show 0.25, 0.5 here and there. And the patient did need a +1 add to jump up from N8 to N6 with a little more ease. And the patient was extremely happy. This is to show you, just as a matter of concept, a preoperative aberrometry showing how classically clear the aberrometry of the cornea would be if the lasers have been done right. And since we're discussing a newer generation right now, and this is how typically a cataract would come up as an internal aberration in the eye. And this is just to show you the post-op of the same patient, showing how strikingly these lenses will perform inside the eye in terms of their optical quality, provided the cornea gives them good field to work on. At 2 months, he's okay. There's a 0.5 and his near unaided is N8, needs a 1.5. And with 1.5 with a little more mag is extremely comfortable. And that's a good post-operative patient with an EDOF lens. This was a VBT lens. This is another patient, 55 years old, and has had LASIK 30 years back, probably a microkeratome because she was operated in New York, because I think that was a fad then to go and operate over there. And this is how the cornea looks. Again, if you notice, it's still a relatively wide zone ablation, and within the pupillary area, it's a regular astigmatism. And the cornea is well-centered ablations. It was a decently done surgery, and this is not a new surgery. It's been done many, many years ago, almost 3 decades ago. This is the right eye of the patient, and I think similarly the left eye of the patient in the right eye. And this is the aberrometry, again showing that even with an older generation LASIK done, but done in a nice proper way, the corneal aberration profile is negligible to none. And whatever is happening at the level of the posterior capsule. And this is a very classical patient. So if you do your workup right, you look at the corneal profile, you understand the patient's requirement. I would go, the only reason why I would not offer them a multifocal lens, if at all, is because of glare and halos. That may be pertinent because of an older generation LASIK done, but an EDOF is absolutely no contraindication in such a clear looking cornea. This is where you really test the eyes. So there's a 72-year-old physician who's had an RK. Now, this is not laser vision correction, but just to prove the point out in the end is this is how the cornea looks for an RK patient.
Just 1 minute left.
Yes, please. 1 minute left. All right. So this is how a cornea looks. It's pulled out on 4 sides, but if you can make out the central cornea is still doing well, We used the online formula calculation, and this is where we landed. We did a bilateral VVT toric implantation for this patient, and we landed with a 6.9 unaided and with a 0.5 learning into 6.6. Patient again needs an add of 1 diopters. So not only for new generation LASIKs, but even for older generation, and even to go for so far ahead as to see regular corneas and post-RKs and post-conductive keratoplasties where we've done these surgeries. This is the same patient showing you the 4 RK cuts that were done some time back. The contrast and the mesopic contrast and the brightness contrast is also well within the normative range, and it's not dropping down with these lenses. And this is documented for all our patients post-operatively. The only thing that you need to tell the patients is they will need glasses for fine print of about 0.5 to 1.25, and there may be a marginal loss in contrast because the light is splitting, because it only is there much light to break up. Again, contraindications are irregular corneas, and that I think is a very simple thing to look into. The staff should be able to pick up irregular corneas and not advise such lenses. Or if you have decentered ablations, is when I will advise a non-aspheric lens monofocal to these patients' eye. The only reason why I would not do a trifocal is because they may land up with dysphotopsia, glare, and halos. But I guess with the EDOF lenses, it's very satisfactory. The outcomes are extremely satisfactory, and the patient does appreciate good range of vision, and you get away with the negative dysphotopsias that probably would have happened had the patient used trifocal lenses. But it's always a good idea, just to end this talk, to always document the patient's mesopic pupil, because at the end of the day, what you're treating is the patient's dim lighting condition at best, and not the bright light, because probably everyone will see good in bright light. So good workup can lead to a good outcome. Thank you.
Thanks a lot, Samaresh, for summing it up all very beautifully. So we have the expert view of Dr. Ramamurthy now.
I think excellent presentations by all three of them, as expected, sharing very similar thoughts to my mind. One of the factors for whenever we talk about presbyopia trifocals is that patient has to be motivated. The very fact that these patients went for a refractive surgery at their younger age group means that they are looking for spectacle independence, and they are prepared to deal with whatever baggage it comes with. And as in all cases, especially in these cases, we always tell them that though we might consider putting in a trifocal or a EDOF lens, there is some expected that it's not refractive accuracy that we'll be able to achieve in every case, but it's more a debulking of the total amount of refractive error that the patient has to deal with. And as Samaresh pointed out, they might need a small correction or a small pair of readers at the end of the surgery, though most often they would be independent or spectacles. Now, of course, one of the challenges in all these cases is that, arriving at the correct refractive power that needs to be implanted. If you don't get that power correct, obviously leave on multifocality or the very fact that a residual spherical or toric cylindrical error will obviate the results. So nowadays we have excellent, as was pointed out again by all the speakers, access to excellent formulae. Our go-to formula is the Barrett 2K formula. And along with this, nowadays we have much of a advantage the total keratometry in virgin eyes. When you with this posterior cornea is altered, when using these 2K TK formula, definitely totally the right formula, the right optical biometry is extremely important. And I would obviously monofocal is often the choice, except in certain areas where the age of the patient at which how many years back the surgery was done was also important, because with some of the earlier lasers, the amount of aberrations that was induced, etc., was much higher. But if it was done in the later part, 2010 and the early 2020s, the quality of aberration itself is much better. And also the amount of refractive error that was treated, if it was a -8, -7, -5 with -4 diopters of cylinder, these obviously the corneas are less suitable for accepting the optics of a multifocal intraocular lens. But if it's a straightforward -3, -2.5 diopters power, which has been corrected as small hyperopic power, again, you can go ahead and deal with a multifocal intraocular lens. And the happiness of the patient that the patient had subsequent to the basic refractive surgery is also important. The patient was never totally comfortable post laser vision correction, had issues of halos, glare, etc., was never feeling that he got optimal results. Such a patient might again not be a good candidate as far as multifocal intraocular lenses. But if the patient had excellent visual outcome after laser vision correction, was happy till the onset of cataract, then maybe these patients could be again considered for a trifocal or EDOF intraocular lenses. Then topography is extremely important, not only for making sure that if there is a cylinder, it's not an irregular astigmatism, but it's a regular bow tie astigmatism, which can also be dealt with the intraocular lens that we are implanting. But also making sure there's not too much of higher order aberrations in the eye. There's excessive higher order aberration, which could be picked up on a eye trace or even in one of the modern day topographers. Then this might be a relative more than a 0.4 higher order root mean square. Then maybe this would be a relative contraindication as far as multifocal implants is concerned. A lot was being talked about by angle kappa, angle alpha, etc. But today, whether it's for multifocals in virgin eyes or for in post-refractive surgery scenario, I think it's less of importance, and more of us are realizing that we need not really emphasize too much on this. Maybe it's beyond 0.7, 0.8 millimeters, you might stay away. But even up to 0.7 millimeters, we go ahead and implant trifocal implants with reasonably good results. And I think did a right thing by differentiating when we came to EDOF lenses, differentiating with the VVT with the other lenses. VVT, that EDOF lenses also includes other lenses like the Symphony, the AT Lara, etc. And those contain diffractive rings. So they are not much different from the trifocal implants. So when you are talking about optics, which is slightly different from the trifocals, basically VVT might be the way to go. And as was pointed out by Samaresh, there is literature evidence to support that these lenses are somewhat more tolerant to a certain amount of aberrations compared to a trifocal implant. So if you want a go-between, when you feel that cornea is not absolutely pristine and ready to receive a trifocal implant, then you could consider a true EDOF lens like a VVT implant. Of course, then you have the additional lenses like the monofocal plus, like the iHands or the Evolex from SIFI, which essentially play around with a slight bit of central curvature change. These lenses, of course, if the patient is not keen on the dysphotopsia that might come with it, but wants something additional, you could consider these lenses, which their optics are almost similar to a monofocal implant, but they give a little extra as far as the intermediate vision is concerned. Because whenever in doubt, whenever you feel that the patient's expectations are not likely to be met, the cornea is not pristine, there's a significant amount of irregular astigmatism or aberrations, then it might be a good idea to go ahead and implant a monofocal intraocular lens. But having said that, as was also mentioned, we are likely to deal with more and more of these patients as time goes on, and they would also expect spectacle independence. And maybe it has also got to be followed up with a procedure. You might do a laser vision correction even before doing the cataract, so as to deal with the higher order aberrations, the refractive error, get a better corneal stages by doing maybe a topo-guided ablation and subsequently implant a multifocal implant. Or if there is a residual error, you could do a laser vision correction. And of course, you could also implant a piggyback lens in case it is needed. I heard an interesting concept in this, just to conclude at the ECRS, where it was mentioned that implant a monofocal implant in the bag and put a piggyback trifocal implant in the sulcus. Wait for about 3 months in case the patient or with the multifocality, taking out a trifocal intraocular lens from the sulcus, a piggyback lens, is much easier compared to taking out an implant from that. And then you leave the patient behind with monofocus. So I think the kind of choices is limited only by the patient's expectations and by our imagination. And kudos to all three of them for giving a very comprehensive presentation. And I believe that there's much sense in what they said. Thank you.
Thank you, Dr. Ramurthy. Dr. Prema, I wanted to ask you a question here. Are you there, Dr. Prema? Dr. Prema, are you there?
Yeah, I'm here, Chitra.
when you are looking at doing a cataract surgery in a post-laser vision correction, would you look at the refractive error? Do you correct a myope or a hyperope for a premium IOL? You think along those directions also, besides the choice of the IOL?
Yeah, I mean, I would say this, Chitra, I think for any patient who's undergone a refractive surgery, a corneal tomography is a must. Not only to look at, as Samaresh said, the centration, but if it is decentered, to rule out a post-LASIK ectasia. Because these eyes would then behave very differently, and all the calculations that you do, imagining that it is a stable refraction may not actually be there if it's a post-LASIK ectasia. So ruling out a post-LASIK ectasia is extremely important. And I will go along with all that has been said by the speakers as well as Ramu. He seldom leaves anything to be added. He's so thorough in the way he sums up things. Yes, I mean, if it is a well ablated cornea, I mean, if it's well-centered ablation, and the patient is willing to accept a small correction cornea, then as Samaresh would have done, I would think an EDOF lens is a good option. But if not, if the eye is aberrated and if there are any doubts about the ocular surface, as Dr. Vijay also pointed out, then that needs to be addressed. But if the ablation itself is not has not been well centered or something, then I would just stick to a monofocal lens.
In that viewpoint, I think I would also add that for a myope, even up to moderate myopes, and you could go ahead if the abrasions are not significant to do a premium IOL, but a moderate hyperope. Of course, nowadays moderate hyperopes also we don't do LASIK, but some of our early hyperopes whom we corrected and are coming for cataract surgery, probably we would think again, because of the complex optics which a hyperope causes. So we may not look at a multifocal IOL in those eyes when we talk about.
But an EDOF lens is still a good option even in those eyes.
Even in those eyes, yes. Yeah, thank you, thanks a lot, Dr. Prema. Dr. Namrata, which would be the formula which you would say is the go-to formula? Are you there, Dr. Namrata? Like, you know, now there is ASRS, there's Barrett's, there's Haigis, which appears logical for you to approach?
So I would say that Barrett 2K is the one which is logical, but then again, I would still, I'll still try to find out what it would be with each of these three formulas.
Yeah, you would like to know whether
what are the other options?
Yeah. Gaurav, are you there? Just one line I wanted. What are your thoughts about the IOL of choice? Like, we know we would look more at a myope than a high hyperope. We would not do a high hyperope. We know about the formula that we would like to look at the three ways of doing it. What about the IOL of choice? What would you feel is the safest?
I most often end up using monofocals. I also end up using EDOFs fairly often. Very rarely I have used trifocals and I've got great results, but then all those things which were discussed are very, very important. But that would be a very, very select choice of patients where every criteria is met. So I'll end up mostly using either monofocals, but I don't hesitate to use torics if I have got a good good looking cornea with proper astigmatism. And I wanted to add to the formulas that we are also using ray tracing now. It's inbuilt into the anterior on which we are using. That seems to be giving good results in some patients, but Ascaris calculator is what I would use because it includes the OCT based calculation, the pentacam based. So it has actually it goes beyond the three formulas that we are discussing. ASRS also has options of adding other sources. So I would strongly recommend that we use that.
Okay, thank you. Thank you.